Hey, future nurses. Today's critical topics for your NCLEX prep: acute respiratory distress syndrome, or ARDS, and respiratory failure. These conditions are life-threatening, with a 50% mortality rate for ARDS, so understanding them is key to providing safe patient care. We'll use the ADPIE nursing process: assessment, diagnosis, planning, implementation, and evaluation, to break it all down, plus some exam tips to help you shine. Let's get started. First up, assessment. When a patient presents with ARDS or respiratory failure, you're looking for signs of inadequate oxygen exchange. Picture this: a 45-year-old patient comes in after a car accident with lung bruising. They're struggling to breathe, with rapid, shallow breaths, tachypnea, and a racing heart, tachycardia. You might notice cyanosis, pallor, or mottled skin. On auscultation, early ARDS may not have abnormal lung sounds, since edema starts in the interstitial spaces, but later, you could hear crackles, wheezing, or decreased breath sounds. Key diagnostics include a chest X-ray showing a whiteout appearance from pulmonary infiltrates and arterial blood gases, or ABGs, revealing hypoxemia. Think partial pressure of oxygen less than 50 millimeters of mercury, despite high oxygen delivery. In kids, look for grunting during expiration. It's their body trying to keep alveoli open. Now, diagnosis. ARDS is a progressive disorder causing acute respiratory failure, where oxygen and CO2 exchange in the lungs fails to meet the body's needs. Fluid buildup in the alveoli from increased alveolar membrane permeability is the culprit. Causes include direct lung injuries like pneumonia, aspiration or smoke inhalation, and indirect issues like sepsis or medication overdose. Risk factors: smoking, alcohol abuse, obesity, or recent chemotherapy. In children, respiratory failure often stems from congenital heart disease, infections, or airway obstructions. For NCLEX, know that ARDS presents with persistent hypoxemia even on 100% oxygen, non-cardiac pulmonary edema, and decreased lung compliance. Always connect symptoms to pathophysiology for a solid diagnosis. Let's move to planning. Our goals focus on improving oxygenation, stabilizing acid-base balance, and preventing complications. For a patient on mechanical ventilation, we aim for a normal ABG pH between 7.35 and 7.45 and adequate tissue perfusion. We also want to reduce anxiety, as it can worsen respiratory distress. In kids, preventing cardiac arrest is critical, since respiratory failure often precedes it. Prioritize measurable outcomes, like maintaining oxygen saturation above 95% or reducing partial pressure of carbon dioxide to 35 to 45 millimeters of mercury. For example, for our car accident patient, the plan includes optimizing lung expansion and monitoring for pneumothorax. Implementation is where we act. Position the patient for maximal lung expansion. Think semi-Fowlers or high Fowlers, with the head of the bed at least 30 degrees. Monitor for hypoxemia and oxygen toxicity, especially in patients on high FiO2. For our patient, you'd check ABGs regularly to assess respiratory or metabolic acidosis. Provide emotional support to ease anxiety, which helps the ventilator work effectively. Implement a mobilization program to prevent complications like muscle weakness. For ventilated patients, elevate the head of the bed, assist with daily sedation vacations, and maintain oral hygiene to prevent infections. Monitor vital signs: cardiac rhythm for signs like peaked T waves from hyperkalemia, and fluid electrolyte balance to avoid overload. In kids, ensure 100% oxygen delivery for severe distress. Evaluation checks if our interventions worked. Look at ABG results. Is the pH closer to normal? Is partial pressure of carbon dioxide between 35 to 45 millimeters of mercury? Check oxygen saturation and tissue perfusion. Skin color and mental status should improve. For our patient, confirm breath sounds are clear, without signs of pneumothorax. In kids, ensure grunting decreases and oxygenation improves. If outcomes aren't met, reassess and adjust the plan. Maybe increase ventilator support or address fluid imbalances. Always document findings to guide ongoing care. Time for hints. Know that ARDS is a catastrophic complication with nonspecific early signs, so prioritize assessment skills. Memorize normal ABG values: pH 7.35 to 7.45, partial pressure of carbon dioxide 35 to 45 millimeters of mercury, partial pressure of oxygen 80 to 100 millimeters of mercury. Practice interpreting ABG's low pH with high partial pressure of carbon dioxide signals respiratory acidosis, common in ARDS. For kids, remember partial pressure of carbon dioxide above 45 millimeters of mercury, or partial pressure of oxygen below 60 millimeters of oxygen on 50% oxygen indicates respiratory failure. Before drawing ABGs, perform the Allen test to check collateral circulation. Sample NCLEX question. A patient with ARDS has a partial pressure of oxygen of 45 millimeters of mercury on 60% oxygen. What's the priority action? Answer: notify the provider and prepare for possible intubation. That's a wrap on ARDS and respiratory failure. You've got the ADPIE framework to tackle these conditions in practice and on your exams. Don't forget to like, subscribe, and hit the bell. Stay confident, nurses. You've got this.